Hello, everyone. Welcome to this evening's Insight Talk. Tonight, you are going to be with Harsha, and he's going to talk to you about obesity. So I hope you'll enjoy.
Hello, very good afternoon. My name is Harsha Disanayak, and welcome to the Insight Talk on obesity. Let's talk about obesity from causes and mechanisms to treatment. As we start off, I think it's good if you could log into slido.com and join as a participant using this meeting ID 2706869. This is because there will be few Q&As, polls, word clouds as we go along so that we get engaged in what we do. But if you have any additional questions as we go along, please feel free to type them in the chat box. I will try and answer maybe at the end of the talk. I try to preserve 5-10 minutes. If not, as we go along, if time permits. Right. So just a bit about the background where I come from. Right. Now this is something. Here we go. I come from the beautiful island Sri Lanka, which is just south of India in the Indian Ocean. It's well known for its heritage, culture, whether it is wildlife, history, archaeology, beaches. That's probably one destination that should be in the top of your list to visit, maybe after exams. So I studied medicine as an undergraduate as well as a postgraduate in University of Colombo, that's in the capital of Sri Lanka. And then I came to this beautiful hospital of Churchill Hospital in Oxford, where I met a lot of beautiful people. Later on, so this was in 2022, later on the same year, I was lucky enough to become a student to study for a DPhil at the University of Oxford. And here I find you in the outreach program through the Balliol College. In terms of clinical specialization, I study endocrinology, which is the study of hormone disorders. It fascinates to me the integrated regulation of endocrine system or the hormonal system, where there's a plethora of endocrine organs that secretes a variety of hormones, but this is tightly regulated. As you can see, all these glands are stimulated by certain factors, and these glands produce a variety of hormones, and they in turn give a feedback inhibition on the central stimulatory signal, which is actually coming from hypothalamus or pituitary, right in the middle of the brain. So if a gland goes dysfunctional, either underactivity or overactivity, the central regulatory mechanism will sense this and make adjustments in its stimulatory or inhibitory signals so that the hormonal environment, the metabolism, function of the organs are all maintained in a steady balance. That's what's fascinating about endocrinology. With this background story, today we are going to talk about obesity. What is actually obesity? What causes it? And how we as clinicians or doctors manage people living with obesity. To set the stage, shall we try this word cloud? When you hear the term obesity, what words come to your mind? If you can just log into Slido, use this meeting ID, or if you have a phone, you can just scan this QR code to gain direct access. And let's see what you have heard of. Just type in a few words. Brilliant. BMI. Oh, excellent start. Keep going. Calorie surplus. Yes, sadness, emotions. Oh, yeah. Meeting ID is perhaps another thing that reminds you. Diabetes, insulin, yes, complications, health risks, mental health problems, disease. Very good. Okay, overweight getting more prominent. Type 2, perhaps you refer to type 2 diabetes. Helplessness, absolutely. Frustrations, people living with obesity, AIDS. Short life, exactly. Heart attacks, among the leading causes that shorten the life expectancy. Risk factor for health problems, Absolutely. Right. The cloud keeps expanding. Let's take another 10 seconds before we move forward. Okay, perfect. Thank you very much. Yes, absolutely. All of you, I think, put in very, very valuable thoughts into this. Now, conventionally, when we hear the term obesity, what comes to our mind is being too heavy, being or having a greater weight. But obviously, people came to realize that weight is, of course, affected by height. If you are taller in height, you have a greater skeletal mass. Your body weight is invariably going to be high. This led to the definition or usage of the term body mass index, which is calculated by weight in kilograms divided by height in meters square. Essentially, this adjusts for the height factor when we look at weight. But then, based on the BMI, we tend to classify people into different categories. We call them normal weight or normal BMI range, overweight, obesity class 1, 2, 3, so forth. As you would appreciate, having too much of weight is bad. Having a high BMI increases the risk of having health problems, but having too little weight is also perhaps equally bad, leading to health problems. So it's just the middle path that works best. Having said all this, thinking of weight and height, is it just a fact? Is it just weight that the fact is? Does it matter what constitutes the weight? How about someone who has a lot of muscle mass compared to someone who has a lot of fat tissue mass or adipose tissue mass? Obviously, obesity has to do with having too much fat. So it's not just about weight, it's about the weight of fat tissue in the body. As we progressed, we also came to realize that it's not only about the mass of fat, but in fact, it's about how the fat is distributed in the body. You would have heard of apple-shaped or upper body predominant obesity, and pear-shaped or lower body predominant obesity. What we have understood over years is that people who have more fat in the upper body tend to run into problems more. When I say problems, metabolic health consequences like fatty liver, diabetes, heart attacks, stroke, cardiovascular disease, all of these. So what it means is it's not just a matter of how many kilos of fat you carry in your body, but where you are carrying it. People who tend to have more upper body fat tend to have more fat in their liver, around their bowel, in their pancreas, likewise. And these tend to make these organs dysfunctional, predisposing one to get metabolic health problems. By the way, why is obesity a problem? Of course, it's pretty common. About two-thirds of our adults in the UK, and for that matter in most of the developed countries, suffer from obesity or overweight state. About one-third having obesity and about one-third being overweight. And what really bothers us is that it causes a lot of health complications. Now, many of these appeared in that word cloud, if you remember. Heart problems, diabetes, cholesterol, hypertension, cancers. Obesity is a well-known risk factor for about 10, 11 cancers at least. Lots of liver issues. What is not mentioned here, but is very important, is something that you all mentioned in the word cloud: mental health problems, mood disorders, depression, anxiety. The list is quite long, so you're absolutely right. Mental health problems are very closely associated with obesity. Just Taking a step back, looking at the bigger picture, how do we know that obesity is a risk factor for these diseases? Just to give you inside story of how epidemiological research operate. This is how we find risk factors for certain diseases or complications of certain diseases. We would look at the general population and then divide them or classify them into two groups. Say, for example, people without obesity and people with obesity. And we follow them up over years and years and then see who develop the outcomes of interest, like how many develop heart attacks, how many go to develop diabetes, etc. So if more people with obesity develop those complications compared to people without obesity, then we know obesity is a risk factor for that outcome. And that is how we have understood over years that obesity is associated with a variety of cancers, diabetes, heart attacks, and everything that we discussed before. So far, I, I assume you would have appreciated that obesity is not just about weight, but it's about excess fat mass. It is a risk factor for many long-term health problems. And let's bear in mind, metabolic effects of obesity are largely due to fat being stored at unsafe sites. In other words, the adipose tissue under the skin, which we call subcutaneous adipose tissue, are designed to store fat. Problems arise when that tissue capacity is overwhelmed. The spillover is then stored in sites where fat is not supposed to be stored, like in the liver, pancreas, as I mentioned. And that is what is causing the metabolic complications. Right, I hope you guys are with me now. Let me just quickly check if there are any questions in the chat. Right, nothing so far. Perfect. Let's get back. So we have looked at what is obesity. We have some sort of a conceptual understanding about what it means. Let's now move on to see what causes obesity. Let's start with another Slido. This time, it's a single best response question, if I may call it, or poll question. What is the strongest risk factor, or what is the strongest factor causing obesity? Excellent. Great start. Fine. Hmm. 14 responses so far, and it keeps increasing. Very good. Sedentary lifestyle seems to be the leader in the board. Right. Let's take another 15 seconds. Right. Okay. Excellent. Sedentary lifestyle, of course, is one of the leading risk factors. Let's try to figure out how all of these operate. Now, this is fairly a simplistic weave of how obesity occurs. Let's start here. In a simplified term, it's about energy intake versus energy spent, and whatever that is left will be stored. That is a simplistic understanding. So whatever the energy that comes in through our food will be spent on variety of things. Basal metabolism is the routine day-to-day activities our cells do even if you are totally at rest, even if you are not moving a single muscle. There's a whole heap of activities happening to maintain the cells intact, to maintain the tissues and organs intact. The heart is pumping, you are breathing, you are thinking, the brain is working. The body temperature is maintained at a steady level. The body metabolites are maintained at a steady level. All of these consumes energy. In fact, about 70% of one's daily energy expenditure is spent on basal metabolism, and another 10-20% on thermogenesis. It's somewhat surprising at times to realize that our day to day physical activity consumes only 10% of our total energy expenditure of the day. So, from the energy that we take in by means of food intake, good chunk is spent on these. Whatever that is left is stored. Now, some of the energy is stored as carbohydrate in the liver and skeletal muscles, while another proportion is stored as fat in our adipose tissue. Now, this is maintained, this is maintained in a tight balance, decent balance, by a system similar to what I showed you in one of my introductory slides. That's a negative feedback mechanism. So the food intake, our ability to eat is determined by our appetite. And our appetite is defined by the nerve function or neuronal communications in the appetite or satiety zones in the brain. These zones receive feedback signals from adipose tissue as well as from the gut. A classic example is leptin, a hormone secreted from adipose tissue. And as you would imagine, as the adipose tissue expands, it produces more leptin and it gives a negative feedback into the appetite centers to say, I'm full enough, stop eating. Similarly, there are a variety of hormones secreted from the gastrointestinal tract that gives a negative signal, suppress appetite, and there are some positive signals that stimulate appetite. Ghrelin coming from the stomach is a classic example. Now, let us dive a little deeper to understand how this system can go wrong or get into an imbalance to cause obesity. To start with, how is our food intake regulated? Of course, it depends on what is out there for us to eat. We know what is more appetizing, and we know what is more dense in calorie, which one is going to give you more energy, which comes in the form of starch, carbohydrate, fat, and proteins. If you think of what you find, if you go to a market, what do you find just before you go to the paying till? You find sweets, beverages, a lot of empty calories. And I struggle to think, do we get anything like fruits and vegetables through a drive-through? You know what convenient food is like? What do we like to see in a meeting table? When we meet our friends, what do we treat ourselves for a birthday with? So this all of these goes on to show us the obesogenic nature of the environment that we live in. This certainly has a strong bearing, and this is thought to be one of the leading driving factors for the rising rates of obesity all around the world. Availability of food and the obesogenic environment. But having said that, we all live in such an environment. Why are not all of us obese like this? We are increasingly understanding how the appetite is regulated within an individual and the diversity between individuals in terms of their appetite regulation, in terms of their regulation of energy balance. the intricate, complex neuronal pathways, some of which you might have heard if you got a chance to listen to Dr. Stanford's video that I shared with you all before the talk. Now, this system is also affected by the plethora of hormonal signals coming from the gut, as well as from the adipose tissue, and even from the liver and skeletal muscle, for example. One classic example is leptin, which I briefly mentioned a little while ago. Now, adipose tissues or adipose tissue cells, which are called adipocytes, these are the cells that store globules of fat. These release leptin. They act in leptin sensitive areas, let's say for convenience, in the hypothalamus. And the ultimate effect is to suppress appetite, reduce food intake, and increase metabolic rates and increase energy expenditure. We have found that there are some people who cannot produce enough leptin. They are leptin deficient. Now, what will happen? The hypothalamus will not get the signal to say that there is enough adipocytes in the body, and there will be no suppression of the appetite. In fact, leptin deficient individuals have a voracious appetite. They continue to consume energy, eat food, and they put on a lot of weight. Now, this also tells you, what about replacing them with leptin? Yes, absolutely. If you ever thought about that, you're absolutely spot on. For people with leptin deficiency, metroleptin is a synthetic leptin molecule which can be used to treat them, which is very, very effective. But unfortunately, it's only a very minority, a very small minority of the obese population that are deficient in leptin. So it's not something that we can use to treat the vast majority of people living with obesity. In fact, most of the others will have leptin resistance. The receptors, the leptin receptors in the hypothalamus are dysfunctional. There are subtle mutations in the genes that code for leptin receptors. So they will not be helped by replacing them with leptin. And that goes on to explain the difficulty in managing obesity. Just like leptin, as you would have seen, there are a variety of other hormones, neurotransmitters, receptors that are involved. And if any of those go dysfunctional, completely, partially, even by a fraction, that means it will push the weight up. It will push the fat mass up. Now, just another look into how we came to understand, how we came to know the genes that are associated with obesity. This is an area of research called genome-wide association studies. Simply put, we look at individuals with obesity and without obesity. We have enough technology to sequence their entire genome. That is, we can sequence the entire length of their DNA in their cells. And then we can find where are the abnormalities or where are the variants, mutations. Then we can find among people with obesity compared to those without. And that is how we understand, okay, if something goes wrong in this gene, that is a risk factor to get obesity. Then kicks in the scientists. They would look in, okay, what sort of metabolic pathways are regulated by the product of this gene? They explore the molecular mechanisms of obesity causing pathways. And this sometimes might unveil or reveal treatment targets. And then the drug development strategists can develop synthetic molecules or proteins to act on those targets and treat obesity. This is where the world is heading. Not only with obesity, but many other diseases where genetics is a risk factor. This is how it is done. As of now, there are about 200, 300 gene variants that have been associated with obesity, depending on how you look at it. A lot of variants predicting BMI, some predicting fat mass, waist, some predicting extreme levels of obesity like BMI 45, 50, 60, 70, for example, and likewise. So that's about regulating the appetite, and essentially what this goes on to tell you is what we eat is not just about what is available to us. It is not just about our willpower. It's about the biology of appetite. It's not something under our voluntary control. Appetite is involuntary, and there's a biological reason why it can be deranged. How about energy expenditure? To be honest, there's not a big variation in basal metabolism among individuals with obesity and without obesity, but possibly it's playing some role there. Sedentary lifestyle was among the leading factors that you all pointed out as a factor causing obesity. You're absolutely right. In fact, sedentary lifestyle is thought to be, is in fact, there's a close relationship between how sedentary we are or how sedentary we have become over years in the recent decades and how fast obesity has increased in its prevalence. Our home environment as well as our work environment is quite sedentary. We spend a lot of time in front of screens, television at home, computers, laptops, games at home, and even our work environment is oftentimes spent on sitting on a chair, staring into a screen. I struggle to think of a single technological advancement, except for exercise machines, that make us work more physically. Technology is there to make things convenient for us. And what is convenient is making us move less from the remote control of the TV to the automobiles for transport. Enough and more examples. So that's about energy expenditure. Right. Let me also briefly talk about energy storage. Now, we alluded to the fact that it is obesity is not just about fat mass, at least in terms of its metabolic complications, where the fat is stored also matters. As I said, subcutaneous adipose tissue, that are the fat stores under the skin, are designed to store fat there. So it's relatively safe, let me say, relatively safe to have fat under the skin. But this brings us to the personal fat threshold hypothesis. Some people believe there is a particular fat mass one could accommodate in their subcutaneous adipose tissue stores. And if you keep overfeeding, and at a point, that threshold will be exceeded, and the spillover will go into liver, bowel, pancreas, causing more problems. Now, one extreme of this scenario is what is called a lipodystrophy syndrome. If you can see these individuals, you can see there is hardly any fat in their limbs. In fact, they look quite muscular. But what's happening here is that their adipose tissues are dysfunctional so that they cannot store fat. So what will happen to their energy? That is going to get into their tummies, into their livers, internal organs. So although they have absolutely normal BMI, they have all the metabolic complications of obesity. This goes on to consolidate the argument that the metabolic complications of obesity are largely because of fat being stored in unsafe sites rather than the safe site, which is the fat under the skin. So, to put things back together, we understood, we discussed that excess energy stored is the difference between the energy that we take in and energy that we spend. Biggest proportion of spent energy is spent on basal metabolism. Then we discussed what determines our food intake. Yes, environment is a strong factor determining this, but there's a big individual one-to-one variation, and this arises from appetite regulation, the complex neuronal mechanisms in the appetite centers in the brain, and how the hormones affect it. Right. And then we discussed about safe storage of adipose tissue or fat. We have looked at what is obesity, what causes it, and now we are going to look how we manage it. And before I do that, let me quickly pop at the chat box to see. Right, so there's a very good question. When fat is stored unsafely, does this mean it is stored as visceral fat? Yes, that's correct. So the unsafe sites are viscera. Viscera are the internal organs like liver, which is the biggest metabolic factory in the body. That is what takes the biggest hit if it is loaded with fat, fatty liver, and all the other complications. Fat can get stored in the pancreas. That causes the pancreas to be dysfunctional, pushing towards diabetes. And fat that is stored around the bowel or the gastrointestinal tract is known to produce a lot of unhealthy chemicals that damages the liver, accelerates the vessel damage, causing atherosclerosis or narrowing of the vessels. Is there a hormone that determines where fat is stored? Good question, tough question. Probably there is a role in hormones, but we fully have not understood it. And this is in fact the kind of research that we do here in Oxford. What determines how the fat is distributed. An example is the hormone cortisol. If you have too much of cortisol, it tends to remove fat from peripheries and bring them to the tummy. So that is a separate disease. Excess cortisol hormone is a disease called Cushing syndrome, and they classically have thin peripheries and they are heavy in the center, central obesity. So that's one example of a hormone that we know well that affects the fat distribution. There probably are more, but still not fully established. Does ethnicity and race impact obesity? Absolutely yes. Uh, Absolutely yes. So let me put it this way. If you think of certain South Asian ethnicities, they tend to have they tend to store their energy more in the form of fat. So if you take two individuals, one South Asian with a BMI of 23 and a Caucasian or a white person with a BMI of 23, invariably the South Asian will have more percentage of that weight in the form of fat. That's their ethnic or racial predisposition. Similarly, South Asians tend to have more upper body obesity than lower body obesity, at least in some of them. Is there any research into environmental factors which could cause mutations which disrupt the nerves or hormones? Absolutely, yes. This is a brilliant question. So this is called epigenetic modification. Long-standing calorie surplus can, in fact, change the way how the genes are expressed. And then that can run into a positive feedback loop, kind of a self-fulfilling prophecy. The more obese you become, the more modified the genes are to accommodate your obesity. And that goes on. There is good evidence about maternal exposures during pregnancy affecting how the genes of the newborn are expressed. And that can push them to obesity. Fantastic. Excellent questions. Right. Let's now move on to see how we manage obesity. Let's take a minute, look at this diagram, which we went through a while ago, and think to yourself, how or what can we do to lose weight, or let's say, reduce the fat mass? Let's take a minute or maybe a half a minute to think how you can do that looking at this. If you want to put something in the chat box, absolutely yes, but just this is a minute for you to think. Okay, yes, someone says reducing food intake. Thanks, Barbara. You're absolutely right. That, in fact, is the most critical step in losing weight. Because we tend to think, okay, I'm going to hit the gym, work out every day, and then I'm going to lose weight. But if you remember what I said, of our energy expenditure, 70-80% is beyond our control. Only about 10-15% is through physical activity. Well, if you really increase your physical activity, you run 5 miles a day, yes, you can increase it by 2-3 fold. But still, it's going to be a difficult task. Nevertheless, essentially, yes, what you can do is you can reduce the food intake, you can supplement that with increasing physical activity, and that should decrease your fat mass. But what really makes it challenging is, as I said at the very beginning, our body is always maintained in a balance. It likes to keep things in balance. If the body finds that the fat mass is getting depleted, it's going to do something to correct it. So, what will happen? As the fat mass depletes, the negative feedback on the appetite centers will decrease, and then your appetite goes up. It counters our efforts to decrease food intake. It's not about willpower. Yes, you need a lot of willpower, but this is the biological response. This is the biological basis why it is difficult to maintain weight loss. You can easily lose weight by going on a calorie restricted diet for a few weeks, couple of months. But the challenge starts at that point. How you're going to maintain it. You're going to fight against your biological adaptations. And another response will be to reduce the basal metabolic rate, and the body will try to conserve energy and maintain the energy store. That's what makes life challenging. Nevertheless, diet, exercise, and lifestyle changes are absolutely the starting point if someone wants to lose weight. And you also mentioned exercise without diet is going to be very difficult because exercise in most individuals will have a good stimulatory effect on appetite and they do tend to overcompensate. Exercise has many health benefits, but when it comes to weight reduction for individuals living with obesity, exercise alone is of doubtful value. You need to couple it with calorie restriction. We need to be wise about the food we choose. Sometimes it's not just about the number of calories we consume, but the quality of food, the type of fatty acids in our food, the type of carbohydrates in our food will determine our appetite, satiety, sense of fullness, and all those things. So essentially, calorie restriction alone in terms of dietary modification and exercise is the starting point. But as I said, it's going to be challenging. And therefore, people have discovered medications, tablets to take. Most of the conventional obesity medications, it's quite interesting to note that they act on our appetite system, they act on our brain. Among them, as far as I know, naltrexone bupropion is available in the United Kingdom. Orlistat was available. So all of these, except Orlistat, act on the brain appetite regulatory mechanisms, the reward mechanisms. Orlistat is acting by inhibiting fat absorption in the gut. How effective they are? Well, as you can see, most of them can lead to a weight reduction of about 5%. And if you're really lucky with this medication, maybe to 9% of weight reduction might be achieved. But mind you, these are from clinical trials, very controlled environments. In real life, the weight reduction that you get might be even less than this. But then think of someone who has a BMI of 50, weighs 200 kilograms in weight. Are we going to achieve a significant improvement by getting them to lose 5% of their weight? Probably not. We need a greater weight reduction. We are now in an era of using hormonal targets to treat obesity. You might have heard of these medications. Liraglutide was one of the first in this class. Wegovy is gaining a lot of attention with recent approval through NICE for weight management. Monjaro or tirzepatide is the new kid on the block, which is yet to be approved, but possibly going to be approved pretty soon for use for weight management. Now, these agents act on hormonal signals. Both liraglutide and semaglutide are GLP-1 analogs or agonists. You might remember GLP-1 is a hormone that is produced by the gut, which sends a signal to the brain to activate the appetite system and give a satiating signal. They suppress appetite. Now, tirzepatide is unique in that it is an agonist of both GLP-1 as well as GIP, another hormone that signals to suppress appetite. Obviously, as you would imagine, it gives a greater weight reduction because it's doing the role of two hormones. As you can see, lifestyle interventions, possibly 3 to 5% of weight reduction, conventional medications in the region of 5 to 10%, semaglutide, tirzepatide, stretching the limit of medical management of weight loss, even up to 20% of weight reduction has been achieved with tirzepatide. As you can see in this diagram, bariatric surgery, as some of you pointed out in the chat box, is probably the most effective in terms of percentage weight reduction. How does it work? We used to think it's either restrictive, it limits your ability to eat a large volume of food by reducing the capacity of the stomach, or either malabsorptive. It diverts food from the stomach, bypassing the digesting zone in the tummy, in the gastrointestinal tract, to more distal parts of the bowel, so that food is not digested and not absorbed. Restrictive procedures, malabsorptive procedures. But over the years, what we have realized is beyond restriction of capacity and restriction of absorption capacity, these surgeries have a strong effect in changing the hormonal environment. And this probably is having a strong influence on high percentage of weight reduction and maintaining that weight reduction over several years. Again, another slight deviation from the talk. How do we know that these interventions work, or maybe they do not work? If you remember the slide I showed you about how do we know people with obesity get more heart attacks, we compared people living with obesity and without obesity, followed them over years to see who develops the problem. And what we do in clinical trials is something pretty much the same. But here we start with a group of people who are obese. We randomly allocate them to receive the intervention, which may be the injection or the operation or the lifestyle intervention that we design. And we have another similar group who are not offered that intervention. They serve as the control group. And then we see how much weight they lose. How many of them lose 10% or more in their body weight. This is what is called randomized clinical trials. This is what the clinical trialists do. Oxford does run a lot of clinical trials on a variety of diseases, not only obesity, diabetes, but many other things. Right. The last poll of the day. If you could log into slido.com, in your view, what is the best treatment option for a person living with obesity? Let's take a minute to cast your vote. Right, perfect. Thank you very much. That's very interesting. Yes, there's a wide range of a wide variety of responses that I can see. And as you can see, it all depends on what it means by best treatment, as you would have tried to guess or think by yourselves. And this is exactly the challenge that we face when we see a patient as doctors. Of course, the severity of obesity is a major determinant. You're not going to waste time just sticking to diet and lifestyle for someone with a BMI of 60. That's nearly impossible to get them to a safe zone with just diet and exercise alone. Sometimes it might not even be possible to modify their diet any further or get them to engage in exercise. So, how severe is the obesity is one aspect. And of course, what the patient wants, what the individual wants. Is it just a short-term weight reduction in preparation for a life event, for a wedding? Or is it more concerned about their long-term health, having a bad experience with some of their relatives or friends suffering complications of obesity? You need to dive into expectations and be realistic in what can be achieved. You also need to think about their other illnesses. Do they have heart problems, kidney problems, diabetes, respiratory diseases? These will change their suitability to receive some interventions. Their lifestyle is a major factor. Some people are so busy they have no time to exercise. How can we motivate them to make a change in their lifestyles? How fit are they for an operation if that's ever a consideration? What are their individual choices? Some people don't want injections, then what can we offer them? So this is the complexity of managing obesity. As you would have seen, there are many causes for this disease. Environmental factors, genes, and then hundreds of genes involved. The more the more there are causes for the problem, the more complex it becomes managing it because you have to address a lot of contributory factors. And that's what we try to do within our healthcare systems. And of course, the biggest challenge we also need to bear in mind is the cost. Is our intervention cost effective? That is why NHS obesity services are arranged in tiers, where surgery is offered only at tier 4 services, and tier 3 services offer medical options, and tier 3 are specialized multidisciplinary teams offering specific interventions like dietary programs, exercise programs, likewise. And tier 1 is just standard advice. Right. So that brings me to the end of the talk. I think I missed one question. Is obesity a physical disability? And I think this is a bit of a tough question for me to answer. I would think obesity is a cause for uh, a variety of disabilities, ranging from musculoskeletal problems like osteoarthritis, then mobility issues, just by virtue of having a higher weight, having to carry a higher weight, and then because of the complications it causes. So possibly, I think I would say obesity is a cause for physical disabilities than causing blankly it as a, a physical disability. But but if you have different thoughts, feel free to express. Many ethnicities have evolved and adapted to hold on to more fat due to the many years of famine. Okay, this means they are more susceptible to obesity, coronary heart disease, and type 2. Is there a way to reverse this for future generations? Right, tough question. So, from an evolutionary point of view, if you really think of changing their genetics, the genetic changes and natural selection, for example, happens over thousands of years. If you look at the problem of obesity, this has risen exponentially over the last few decades. So this is certainly not a time scale long enough for genetics to change and natural selection to play a role, although it is possibly playing some role here. That's why we tend to believe it's largely because of environmental changes, which has actually happened pretty fast, evolved pretty fast over the last few decades. So, if there are any genetic selections that have taken place to let South Asians hang on to more fat in their body, is there a way to reverse this for the future generations? Well, changing the genetic landscape, genetic makeup of an individual is not an easy task. We do we do offer gene therapy for certain other diseases, but these become effective only if there is a single gene that is dysfunctional. In the case of obesity, it's a big set of genes. Therefore, I don't think genetic manipulation like gene therapy is going to be effective for the vast majority of people living with obesity. In contrast, if you really think uh, what can be done, it's probably a big overhaul or big change in our lifestyles, in the food that we eat, and how we exert ourselves physically. But then the interests of industry, finances, busy lifestyles, occupational demands, it really throws a lot of questions to see how feasible this is in the long run. Right. Any more questions? I think I missed one question right at the beginning. Can we find links between genetic factors that cause endocrine issues being an underlying cause of sedentary lifestyle? I'm personally not aware of genetic factors or genetic problems causing hormonal imbalances that make us sedentary. But this probably uh, goes into the realm of behavioral sciences, behavioral psychology. I know individuals' behavior has a genetic basis, but I'm not entirely sure if there are if those genetic links between, or the links between genetics and sedentary lifestyle is mediated directly through endocrine factors. That's going to be something very interesting to dive into, but to my knowledge, I'm not aware of any. Would you say that the vast number of COVID cases in ethnic minority populations was caused by diet-related diseases that these groups suffer from? Interesting question. Obesity is definitely a risk factor to get COVID-19 as well as to develop complications from COVID-19. So, obesity is possibly more prevalent in ethnic minorities, and this, yes, could very well be a reason why they were more susceptible to COVID and to its complications. Does semaglutide cause weight loss or help with weight loss? So semaglutide and liraglutide are you can think of them as hormonal analogs that send signals to the brain to activate their satiety centers. Okay, so it's not that semaglutide directly causes weight loss by semaglutide acting on adipose tissue and burning them out. Instead, it acts on the brain where energy balance is regulated. It stimulates satiety and maybe increases metabolism and thereby create a negative energy balance that that leads to weight reduction. Any more questions? Right, so in the absence of other questions, let me just wind up. So we looked at what is obesity, we discussed it's about fat mass, and the problem is when fat is stored in unsafe sites. And we discussed the biological basis of obesity and understood that it is a disease in itself rather than a lifestyle choice. It's not about your willpower, but it's the biology. And we also understood obesity as a strong risk factor for a plethora of long-term health conditions. We looked at the simplistic view of energy balance and how the complex genetics interact with environmental factors in causing obesity. And finally, we looked at the diverse options available to manage obesity with, how the services are arranged, and the challenges we face, with the multiple aspects we need to consider when we treat an individual living with obesity. That is the end of my talk. Here are some useful resources. So European Association for the Study of Obesity has some nice resources for someone who wants to learn more. There are nice YouTube videos. If you can search for these two scientists, Professor Sir Steve or Rahili from Cambridge, Professor Frederick Karp from Oxford, who is in fact my supervisor. They have some nice short clips that you can find more information on obesity and its science behind it. If you still want to send me more questions, feel free to email this address. I will try to answer them or give you more resources whenever possible. One last question. Do you think sleep deprivation is a factor increasing obesity? Yes, there is a link between poor sleep, quality of sleep deprivation with obesity. That goes into the association between appetite regulation centers and circadian rhythm centers, another very fascinating area of research.
That was brilliant, Harsha. Thank you so much. I found that really interesting. Clearly everyone else did from the number of questions you got. There were really good questions sitting back, sort of listening to that. It's really impressive, the sort of quality and the thought that goes into some of the questions. So yeah, thank you so much for your time. Thank you everyone for attending. The links that are on here, you'll get in a follow-up email, and you'll also get the link to the recording of this session as well if anyone wants to watch it again, and make any notes and stuff going forward. But yeah, thank you all for attending, and thank you, Harsha, for a really interesting talk. Good night,
Most
everyone.
welcome. Have a good day all. Bye bye.